Hello everyone, good evening. I hope I'm audible and visible to all of you. If yes, kindly give me a quick thumbs up or a confirmation that you're able to see me and listen to me. So I hope I'm audible and visible to all of you. Today's session is going to be focused mainly on understanding the previous year's questions, and we are going to do a few questions. Although there are many, the priority is going to be 2022, 2021 and the INI-CT questions, so that you're prepared for the examination. Good evening, Dr. Sharad, Bhavesh, Dr. Sudhanshu. Thank you for the confirmation that all is well. So we will start the session very quickly without wasting any time. So today's session, these are going to be all the PYQs, mainly of the last 3 years is what I'm going to focus on, 2022, 2021 and the INI-CT papers, so that you're very thorough with at least the latest questions in ENT and you feel confident before going to examination, because PYQs are a must do before you go to the examination, and this is something that you have to cover before examination. So why don't you do it with me and we will be able to solve it together. So with this, let's start the class. While we have more learners joining in, let me just tell you what we have on offering from Unacademy. So we have the NEET PG Vitals. So this NEET PG Vitals is the recorded version where I have recorded the entire content for ENT, and now we're launching it at a very special price of 11,999. You can use the code ENT10 to get another 10% off. We have the batch called as Last Leap Marathon, where we are going to do a 1 month batch, and this is going to be 102 hours of dedicated rapid revision. So high yield topics, must know topics will be covered in this batch. Since we're celebrating our Republic Day and we are offering 20% off on all the medical PG subscriptions, this is only for this valid only till 28th of January. Again, you can use the code ENT10 to get another 10% off. So with this, let's begin the class. Stimulation of external auditory canal leads to cough due to which nerve? Auricular branch of the vagus nerve, greater auricular nerve, auriculotemporal nerve, facial nerve. Again, this is the 2022 NEET PG question. So this is a basic question which we often study during our preparation, like one of the first topics, understanding the anatomy of the ear. So I think most of you should be able to answer this. Very good, Sayak, Dr. Sudhanshu, Dr. Bhavesh, Dr. Sayak. Very good. The answer is A. It is auricular branch of the vagus nerve, which we call it as Arnold's nerve. So if we take the external auditory canal, the roof and the posterior wall of the external auditory canal, roof and anterior wall are supplied by auriculotemporal nerve. So the nerve supplying the roof and the anterior wall is auriculotemporal nerve, whereas the floor and the posterior wall is by the auricular branch of the vagus nerve, which we call it as the Arnold's nerve. So the floor and the posterior wall is by the auricular branch of vagus nerve, which we call it as Arnold's nerve. Now they can ask you a question, right now they have given you a question regarding cough in the examination. They can always ask you a question where they can mention you during removal of a wax, a patient had a vasovagal attack, or while probing the external auditory canal, a patient coughed, while doing removal of wax, the patient had vertigo. What could be the cause? Then you should be able to tell that it is auricular branch of the vagus nerve. Pickle, I'm trying to use the thick pen, but I don't know, somehow it doesn't seem to work with my PowerPoint. So I am trying. I did take your input even last time, but it's not working for me. Otherwise I would have done. But anyways, let me try and see if the pen thing gets a little thicker. Okay, so let's see. I'll try my best, Pickle, but let's see how it goes. Okay, a operative technique where you widen the lateral cartilaginous portion of the external auditory canal is called as otoplasty, myringoplasty, tympanoplasty, meatoplasty. So please try to answer what is this operative technique where you try to widen the lateral cartilaginous portion of the external auditory canal. Yes, most of you are absolutely right. The operative technique where we widen the lateral cartilaginous portion of the external auditory meatus, we call it as meatoplasty. Okay, so pickle, for you I will write it a little bigger so that you will be able to remember and understand. I will not write smaller. So whenever we do a widening of the external auditory canal, we call it as meatoplasty. So when we are doing a modified radical mastoidectomy, we create a big cavity. This big cavity has the middle ear, has the bony portion of the external auditory canal, and it has the mastoid. So to be able to visualize all of these three structures, the mastoid, the middle ear and external auditory canal, you should be able to have a wide external auditory meatus. So to be able to visualize the mastoid cavity, the middle ear cavity, we do a surgery which is called as meatoplasty. Okay. So I hope you got the answer. Otoplasty is when you reconstruct the pinna. Myringoplasty is when you repair the tympanic membrane. Tympanoplasty is repair of tympanic membrane and the middle ear. We call it as tympanoplasty. Okay. So let's go to the next question. Tubercular otitis media is characterized by all except painful otorrhea, multiple perforation, pale granulation, foul smelling ear discharge. So tubercular otitis media is characterized by all except. So what is not a feature of tubercular otitis media? This is again a very important, a very high yield topic where they can give you an image based questions also in the exam. So you should be able to understand that in tubercular otitis media, the hallmark is multiple perforation. So this is the hallmark of the disease, which is multiple perforation. So hallmark is multiple perforation. You have pale granulation because it's a chronic disease. There can be foul smelling ear discharge and there can be hearing loss that is disproportionate to the disease. But painful otorrhea is not a feature of tubercular otitis media, and that's your answer. Tuberculosis is painful only in the larynx. Rest everywhere it is a painless condition. Painful tubercular condition is your laryngeal tuberculosis. So laryngeal tuberculosis is the only painful condition. Okay. Let's go to the next one. Partial closure and full closure of nose is done in. So where do you do partial closure and full closure of the nose? In atrophic rhinitis, allergic rhinitis, vasomotor rhinitis, occupational rhinitis. Where do you do partial and full closure of the nose? This is something that again is a very common question. Where do we do Young's operation? Where do we do modified Young's operation? This is something that you should know by now. Yes, all of you are absolutely right. Young's operation and modified Young's operation are the surgeries that you do for atrophic rhinitis. So initially you will give washes with alkaline nasal douching solution made up of sodium chloride, sodium bicarbonate, sodium biborate, and you mix it with 280 ml of water and ask the patient to irrigate the solution in the nose. The crust keep falling and the nose become moist. There are other medical solutions also like glucose and glycerine. You can give estrogen extracts and you can give placental extracts. But if it fails, then the surgeries that you do is called as Young's operation, modified Young's operation, also one more which is called as Lawton-Slager's operation. So these three surgeries aim at basically reducing the nasal cavity passage so that the amount of air that goes into the nose is reduced and the crusting is reduced and the dryness is reduced. So these three surgeries are done for atrophic rhinitis. Yes, Sayak Chakrabarti, Young's operation, not others. Young's operation is also done in a patient with severe epistaxis and has hereditary hemorrhagic telangiectasia. So one indication of Young's operation is atrophic rhinitis. The second one is hereditary hemorrhagic telangiectasia presenting to you with severe epistaxis. Okay. Okay, let's go to the next one. Occipitomental view of the PNS is called as. So occipitomental. So the ray of X-rays coming from the occiput to the mentum. What do you call this view as? Caldwell's view, Waters view, Townes view, or Pine's view? This is again a very common question. So please do make a note of X-rays of the paranasal sinuses before you go to the examination, because these questions do keep occurring on and off. Very good. So occipitomental view, how will you remember? Whenever we speak of mental view, reverse M, what will you get? W. So occipitomental view is your Waters view. So isn't it very easy? And occipitomental view or Waters view, M for M, it is used for maxillary sinus. So if you see all the three are interconnected, maxillary sinus, MU reverse, you get W, and MU reverse from occipitomental view, you get W. So Waters view is for maxillary sinus. So it is the best view for identifying the maxillary sinus. Whereas Caldwell view, this is the best view for identifying the frontal sinus. So Caldwell's view is occipitofrontal view, which is the best view for identifying the frontal sinus. Okay, and we have got Townes view, which is for temporal bone. It has nothing to do with the paranasal sinuses. Okay, let's go to the next question. I'm doing a little faster because there are a lot of questions to discuss. So I'm just going for a brief explanation for all of them. If you have any specific doubts, you can mention in the chat box. I'll be more than happy to help you. Okay, so endolymphatic hydrops is seen in otosclerosis, in Meniere's disease, acoustic neuroma, or cholesteatoma. Where do you see? This is something that again is a very high yield chapter. Meniere's disease, glomus tumor, otosclerosis, acoustic neuroma, cholesteatoma. These chapters you cannot afford to go and to enter the examination without having read this chapter. So please do read these all chapters that you have in options. So these chapters are very, very high yield and you can expect questions coming in from here. Endolymphatic hydrops is nothing but Meniere's disease. So Meniere's disease is a condition, as the name suggests, hydrops. There is increased endolymph production and there is decreased reabsorption. So there is increased endolymph production and there is a decreased resorption. As a result, the membranous labyrinth is full of endolymph, and this full of endolymph will increase the pressure in the membranous labyrinth, resulting in vertigo, VST. The triad is VST. You get vertigo, you get sensory neural hearing loss, and you get tinnitus. Now this vertigo is not constantly present. It is present only for a few minutes to few hours and it is associated with nausea, vomiting and vagal symptoms. Hearing loss is fluctuating. Low frequency hearing loss is the typical feature. You will get diploacusis. Now diplophonia question came in the latest examination for FMG. So they can ask you diploacusis in the next examination. So please do keep a note of diplophonia, which is a feature of endolymphatic hydrops or Meniere's disease. The tinnitus that you see is called as roaring type of tinnitus. Okay. Yes, so let's go to the next question. True regarding ranula. It is a cystic swelling in the floor of the mouth. It is also known as epulis. It's a type of thyroglossal cyst. It's a type of mucus retention cyst. So Sayak, yes, Pierre's view is Waters view with mouth open, which we do for sphenoid sinus. But they had given the option of Pine's view, not Pierre's view. Okay. Okay, so true regarding ranula. What is ranula? Yes, it is a cystic swelling in the floor of the mouth is the correct answer. While I see some of you have answered it as mucus retention cyst. Ranula is most commonly an extravasation cyst. This MCQ is a mistake by many students which I have seen in the last examination also. It's not a mucus retention cyst, it's an extravasation cyst. What is an extravasation cyst? Now this is your sublingual salivary gland and this is the duct of the sublingual salivary gland. Now whenever there is a trauma to the duct, what will happen? The saliva will extravasate from the duct. Around that extravasated saliva, you will have a cystic transformation, and that cystic transformation around the duct of the sublingual salivary gland, we call that as ranula. Okay, so ranula is not a mucus retention cyst. Most commonly it is an extravasation cyst. It is not called as epulis. It is not a type of thyroglossal cyst. It is a extravasation cyst of the sublingual salivary gland. Now even though it is coming from the saliva, extravasation that's happening from the duct, the treatment will be excision of the sublingual salivary gland. So you will do excision of ranula plus sublingual salivary gland. So you are going to do excision of ranula plus sublingual salivary gland for a patient with ranula. Okay, I think this is something that you can expect as your next MCQ. Having asked a question on ranula, they can always ask you treatment. So you will have to excise dark night and you will have to excise the sublingual salivary gland also. No, Sayax, marsupialization is not done because it will cause recurrence. You have to take the entire gland out, then only there will be no recurrence. Otherwise, ranula is known to recur very, very often. Okay. The time of occurrence of secondary hemorrhage after tonsillectomy is 24 hours, 6 days, 12 days or 12 hours. So what is the time of occurrence of secondary hemorrhage after tonsillectomy? Whenever we classify tonsillectomy hemorrhages, we classify it into three types. We classify it as primary hemorrhage, we classify it as reactionary hemorrhage, and we classify it as secondary hemorrhage. Okay, so primary, reactionary and secondary. So primary hemorrhage is if you have a bleeding at the time of surgery, meaning during the surgery intraoperative, if you get a bleeding, that is your primary hemorrhage. Reactionary hemorrhage is any bleeding that happens after surgery until less than 24 hours, you call it as reactionary hemorrhage. And secondary hemorrhage is anything that happens from 24 hours onwards up till 14 days. We call it as secondary hemorrhage. Now the cause of primary hemorrhage is usually bleeding from the peritonsillar vein or from the tonsillar artery. Reactionary hemorrhage, the commonest cause is slipping of ligature. So if there is slipping of ligature that you have applied during surgery, then that is the cause of reactionary hemorrhage. And the cause of secondary hemorrhage is usually infection. So infection is the cause for secondary hemorrhage. Okay, so all of you have mentioned it right. So typically anything that happens after 24 hours up till 14 days, you call it as secondary hemorrhage. So actually 6 days, 12 days, both are the right answers. There is an ambiguity of the options given in the examination, so which is why I have mentioned whatever the students had told me. But if it is 6 days or 12 days, both should be the right answer. Okay. A 5-year-old boy, while having dinner, suddenly becomes aphonic and is brought to the casualty for complaints of respiratory distress. What should be the next management? Heimlich's maneuver, cricothyrotomy, emergency tracheostomy, humidified oxygen. So Mayank, reactionary hemorrhage is any bleeding that happens after surgery up till 24 hours. Whenever there is an artery that has bled or a vein that has bled, you'll apply a ligature around it to stop the bleeding. If that ligature gives way, then there can be bleeding. So immediately you have to take the patient in a reactionary hemorrhage to the operating theatre and again religate the blood vessel. Okay. Okay, so 5-year-old boy while having dinner becomes aphonic and is brought with respiratory distress. So what should be the next line of management? Whenever we have a foreign body in the airway, why are we thinking is this foreign body in the airway? Because the child is having respiratory distress and the child is also having aphonia, unable to speak. Aphonia usually indicates a laryngeal foreign body, because if there is a foreign body in the larynx, they will have an associated difficulty in speaking also. Doesn't mean that it doesn't happen in tracheal foreign body, it can happen in tracheal as well, but commonly when there is a laryngeal foreign body they will have aphonia. And now when the child was having dinner developed suddenly means the child has aspirated that foreign body or the meal into the airway. So in this situation the first step would be to do a Heimlich's maneuver. If the Heimlich's maneuver doesn't work or if the child is deteriorating, then we are going to go for emergency tracheostomy or cricothyrotomy. So basically when we have an inhaled foreign body, you have to assess the severity by checking the cough. If there is an ineffective cough and the patient is unconscious, you will have to start the CPR, meaning cough is not there, patient is unconscious, means that the saturations are falling. You will have to start the CPR, give 5 breaths and chest compression. If the patient is conscious, you can give 5 back blows or 5 thrusts, which we call it as, see, above 5 years of age you can do this Heimlich's maneuver, below 5 years you are going to give back blows. And if there is an effective cough, it means that the airway is trying to push the foreign body out, so you have to encourage the child to cough and continue to check if there is any further deterioration. So this is the basic first step in the management of any foreign body that you have in the airway. Now again, whenever there is a foreign body, there is always a question. In the recent FMG we had a question, in INI set we had a question, in NEET PG we had a question. So in ENT emergencies, epistaxis, airway foreign body, stridor, these are constant things that could come. Not just airway foreign body in ear, nose, throat can be questions. So in ENT part of you, please remember to learn these 3 emergencies, because as a undergraduate you are expected to know how to manage these emergencies. Okay, pain sensation from the ethmoid sinus is carried by which nerve? Is it the frontal nerve? Is it the nasociliary nerve? Is it the lacrimal nerve? Or is it the infraorbital nerve? Yes, Pickle, I have included the AIMS questions and the INI-CT questions. Sayak, these are not FMG questions. These are all NEET PG questions. These are NEET PG 2022 questions. After this, I'm going to do 2021. Then I'm going to do INI-CT also. Okay. Karthik, I hope you got your answer for your question. Yes, so the pain sensation from the ethmoid sinus is carried by nasociliary nerve. So this is something that you will have to remember, that anterior and posterior branches of the nasociliary nerve supply the ethmoid sinuses. So this is a memory based question. There is nothing that you will have to understand the concept behind. Onodi cell and Haller cells are associated with which of the following structures respectively? Optic nerve and orbital floor, optic nerve and internal carotid artery, optic nerve and ethmoid layer cells, orbital floor and internal carotid artery. RK last question was nasociliary nerve. Before that it was Heimlich's maneuver. Yes, very good, all of you. Most of you have answered this absolutely right. So Onodi cell is a posterior ethmoidal cell. So if we take this as our sinuses, we have the ethmoid sinuses which are sandwiched between your frontal sinus anteriorly and the sphenoid sinus posteriorly. So in between them we have got the ethmoid sinuses. Now these ethmoid sinuses should not pneumatize into the sphenoid, but if we have the posterior ethmoid sinus going into the sphenoid, then we call that cell as an Onodi cell. This Onodi cell can have in relation to it the optic nerve and the internal carotid artery. So the two structures that could be present in relation to the Onodi cell is your optic nerve and the internal carotid artery. Now what is a Haller cell? Now when we talk about the extent of the ethmoidal air cells from medial to lateral, meaning what is there medially and what is there laterally, if we take this as the nose and if we take the eyes, in between them we will have the ethmoidal air cells. So ethmoidal air cells are sandwiched between middle turbinate and superior turbinate medially, and the medial wall of the orbit laterally. So what is there medially? We have got the turbinates medially, and which wall of the orbit laterally? Medial wall of the orbit laterally. So if we have a cell that is present inferior to the orbit and medial to the orbit in relation to the orbital floor. So if we have a cell in relation to the orbital floor, we call that cell as Haller cell. So Haller cell is a air cell that is present inferior to the orbit and medial to the orbit. Okay, so I hope all of you got what is a Haller cell and what is an Onodi cell. Okay, let's go to the next question. Drug of choice in laryngeal stenosis is cyclophosphamide, doxorubicin, adriamycin, mitomycin. Now obviously whenever there is a stenosis, you are going to dilate the stenosis, resect the stenosis, reconstruct the stenosis, but drug of choice means what drug will help you to prevent restenosis. Again, I am sure all of you know the answer to this question. Absolutely right, Karthik, Medico, Kezia, Priya. Very good, Jaipal. The drug of choice is mitomycin C. So mitomycin C is a anti-proliferative agent. It inhibits the proliferation of the cells and hence it prevents restenosis. So topical application of mitomycin is used whenever there is a stenosis or whenever there is a problem of adhesions. Like say there is a nasal synechia causing obstruction to the nasal airway, and this is happening again and again. You can put mitomycin. Laryngeal stenosis, tracheal stenosis. To prevent restenosis, you can apply mitomycin C. Okay, let's go to the next question. A child presents with stridor, barking cough and difficulty in breathing since 2 to 3 days. He has fever and an elevated leukocyte count. All the following statements about his condition are true except antibiotics form the mainstay of treatment. Boys are more commonly affected than girls. Symptoms are predominantly caused by involvement of the subglottis. Subglottic stenosis and hypopharyngeal dilatation may be seen on the X-ray. So all are true except. So whenever you have okay, so Priya, yes, it is good for mitomycin is good for radiation recall injury also, because in radiation there is necrosis of the cartilages. So to prevent adhesions and stenosis, you can apply. Yes. Okay, so whenever we are talking about stridor, when we are talking of a barking seal-like cough, difficulty in breathing, fever and an elevated leukocyte count, can you tell me what is the diagnosis here? What do you think is the diagnosis in this patient? Can we say the diagnosis is croup, which is nothing but laryngotracheobronchitis? Yes, this laryngotracheobronchitis is caused by para-influenza type 1 and type 2 virus. So it is caused by para-influenza type 1 and type 2 virus. Even though it's a viral infection, do we give antibiotics to prevent superadded bacterial infection? Yes, we do give antibiotics to prevent superadded bacterial infection, but do they form the mainstay of treatment? No, the mainstay of treatment is steroids to reduce the airway edema. The mainstay of treatment is bronchodilator to help ventilation of the lungs. So that forms the mainstay of treatment. Antibiotics are given as an adjunct to therapy to prevent secondary bacterial infections. Symptoms are commonly seen here because of subglottic stenosis, where we see a sign called as the steeple sign. That steeple sign is the hallmark where you see a subglottic narrowing resembling the steeple of the church. So antibiotics form the mainstay of treatment is the wrong answer. Yes, Karthik, Budecort nebulization, adrenaline inhalation, steroid inhalation are given for patients with croup. Okay, which of the following structures is not seen in bronchoscopy? Trachea, subcarinal lymph nodes, vocal cord, first segmental division of the bronchus. So what do we not see on a bronchoscopy? So when we are doing a bronchoscopy, what are all the structures that we can see? Yes, I am waiting to listen. Most of you have got it right. Yes, so when we are doing a bronchoscopy, we will pass the bronchoscope first from the nose, commonly from the nose. So we evaluate the nasal airway, nasopharyngeal airway, oropharyngeal airway, and we go to the larynx. In the larynx, we can see the epiglottis, aryepiglottic fold, false cords and true cords. After passing the vocal cords, we go into the subglottis, and from the subglottis, we can go into the trachea. From the trachea, we can also go to the first division of bronchus. Sometimes we can go to the second division, but first division we can always see. So these are the structures that we can see on bronchoscopy. But lymph nodes which are below the carina, can we see them? Of course not. So subcarinal lymph nodes cannot be seen. We can see trachea, we can see vocal cord and the first segmental division of bronchus. Okay. So all of the following are extrinsic membranes or ligaments except. So which of them is an intrinsic one is what you have to answer here. Very good. Most of you are answering it absolutely right. So what is the meaning of extrinsic membrane and intrinsic membrane? Any membrane that connects one laryngeal structure to another laryngeal structure, we call it as intrinsic. One laryngeal structure to an extra laryngeal structure, we call it as extrinsic. Okay, so if we say this is our airway, let me label these structures. The first one that we see is the hyoid bone superiorly, which is not a part of the larynx. Then we have the thyroid cartilage, which is a part of the larynx. Below that we have the cricoid cartilage, which is the part of the larynx, and then we have the tracheal rings. Okay. Now what will be the name of this membrane that is present between the thyroid and the hyoid? Can I call this membrane as thyrohyoid membrane? Yes, so this is your thyrohyoid membrane. So is it connecting laryngeal structure to an extra laryngeal structure? Yes. So does it form an extrinsic membrane or intrinsic membrane? So thyrohyoid membrane is your extrinsic membrane. Absolutely nailed it. It is your extrinsic membrane. Now look at this membrane which is present between the cricoid and the thyroid. Cricoid is a laryngeal structure, thyroid is a laryngeal structure. So what is cricothyroid membrane? Is it intrinsic or is it extrinsic? Absolutely right, all of you. This is an intrinsic membrane. What is intrinsic? Connecting one laryngeal structure to another laryngeal structure. We call it as intrinsic. Okay. Now we have the membrane between cricoid and the trachea, which we call it as cricotracheal membrane, connecting larynx to an extra laryngeal structure. So cricotracheal is also an extrinsic membrane. And if we see the larynx on the side view, we will have a ligament here between the epiglottis and the hyoid. Again, it is connecting laryngeal structure to an extra laryngeal structure. So it is an extrinsic membrane. So this is an extrinsic membrane as well. So only intrinsic one is cricothyroid. So if you know the principle, larynx to larynx is intrinsic, larynx to extralaryngeal is extrinsic, you will be able to answer any question given to you in your exam. All the following statements about nasopharyngeal carcinoma are true except there is a bimodal age distribution, IgA antibody to EBV is observed, nasopharyngectomy with radical neck dissection is the treatment of choice, squamous cell carcinoma is the most common histopathological subtype. Now this is again a very important topic. If you see in the last few years, juvenile nasopharyngeal angiofibroma and nasopharyngeal carcinoma are the common repeat topics where you're getting questions from. You cannot miss to learn these topics or revise these topics. They hardly take 5 minutes. You just have to revise them quickly before your examination, and typically I give comparative charts for those topics where you get a lot of questions, like say nasopharyngeal carcinoma, angiofibroma, epiglottitis, croup. So if you guys are interested, let me know. I can do a class on only charts and last minute revision, and the charts that will summarize the information of almost all important ENT diseases. So once you are ready to learn it, I will be there to teach you. So let me know if you guys are interested in that. Maybe in the next upcoming class on an academy on YouTube, I can do that. Okay, so nasopharyngeal carcinoma has a bimodal age group distribution is true. Epstein-Barr virus is a very important contributing risk factor. So IgA antibody to Epstein-Barr virus can be seen. Squamous cell carcinoma is the most common histopathological type, but the treatment is radiation. So external beam radiotherapy is the treatment of choice. Nasopharyngeal resection or radical neck dissection is not done for nasopharyngeal carcinoma unless there is a recurrence. So the primary treatment is radiation therapy. So that will be the treatment for nasopharyngeal carcinoma. Otoacoustic emissions arise from outer hair cells, inner hair cells, or organ of Corti, both outer and inner hair cells. Where do you get otoacoustic emissions from? Sure, I think most of you are wanting me to do a quick session on revision and a session that most expected questions can come from. Yes, there are certain topics which are must to do in ENT, or we can do a quick session of 1 hour where we can discuss all important topics, at least like how for every popular dance number there is a hook step. We are going to try to recollect almost all the topic with a hook line or a hook mnemonic or a hook punch line, something like that, so that your memory becomes more stronger before you go to the exam. I have prepared that, but maybe once you're closer to your examination we can do that. Yes, so otoacoustic emissions arise from the outer hair cells. So typically when we say the hair cells in the organ of Corti, there are two types of hair cells in the organ of Corti. We have got the type 1 hair cells and we have got the type 2 hair cells. Sure, Ashish, sure, Mayank, we can always do that, and this is something that I have come up new with, because as an educator I need to provide you with better content each time I come on the platform, and I do keep working really hard for it, and I hope that you guys like those content as well. Fine, we will do it one session on YouTube, one plus class also we can have it. Yes, so here we have type 1 hair cells. One eye resembles the same, right? So type 1 are inner hair cells. The first alphabet in your English is A, so it is your afferent hair cells, and 1 means single, right? So they are single hair cells. And here you have type 2 hair cells, which are outer hair cells. They are efferent hair cells, and they are not single hair cells, but they are multiple hair cells. So if you are asked a question, otoacoustic emissions, meaning we are recording the emissions in the external auditory canal which is coming from the cochlea. So we are looking for efferent emissions. So which one is efferent? It is your type 2 hair cells or your outer hair cells. So don't get confused. Type 2 is outer, it is multiple, and it is efferent. Okay, it's easy to remember and recollect like this. So now let's recall 2021 questions. All of you are ready? NEET PG 2021 questions, or are you all tired? How are you feeling? Okay, thank you Jaipal for that lovely comment. Let's continue. A patient presented with complaints of nasal obstruction and there is a greenish crust in the nasal cavity. There is merciful anosmia. What other finding can you expect? So if you see 2022, they asked you surgical therapy for atrophic rhinitis, and 2021, what did they ask you? They ask you symptomatology. So does that mean you from same topic different questions are coming? So we need to track down all these topics, which is not your job, my job of course, and I'm going to teach all of this in the coming classes as well. Yes, so patient complaining to you with nasal obstruction, there is greenish crust, merciful anosmia. The word merciful anosmia should be sufficient to give you the diagnosis of atrophic rhinitis. So in atrophic rhinitis, there is atrophy of the mucosa of the nose, of the paranasal sinuses, there is atrophy of the olfactory epithelium. Because there is atrophy of the mucous glands, the nose becomes dry, there is crusting in the nose, there is foul smell coming in the nose. So they have wide roomy nasal cavities. Despite having wide roomy nasal cavity, they complain to you of nasal obstruction. So they do not have polyp or turbinate hypertrophy or a foreign body. They have wide roomy nasal cavities. Despite having wide roomy nasal cavities, they'll tell you that they're having nasal obstruction. That is a paradoxical phenomenon that you see in atrophic rhinitis. Okay, a patient with CSOM presented to you with headache. vomiting. One second, let me just change the slide so that it becomes oh, 1 second. Okay, fine. So I'm not able to change it, but let's see. I'll be able to tell you the question at least. So a patient with CSOM presented to you with headache, with vomiting, and neurological deficits are there, and the imaging is given below. What is your diagnosis? Is it meningitis? Is it extradural abscess? Is it temporal lobe abscess, or is this cerebellar abscess? Yes, correct. All of you have marked it absolutely right. So basically, whenever you are in a doubt, first of all, when they are telling you CSOM, chronic suppurative otitis media, and there is a complication. Now, image is showing to you some well circumscribed lesion, so it cannot be meningitis. It has to be one form of abscess. Now, this is not outside the brain to call it as extradural abscess, so it has to be a brain abscess. So these two options are ruled out. Now we are left with only temporal lobe abscess or cerebellar abscess. Now how do we understand? Basically, your roof of the middle ear separates the middle ear from middle cranial fossa containing the temporal lobe of the brain. Now even if you didn't know that anatomy in your examination, let us just see. Can I say this is the frontal? Can I say this is the temporal and this is the occipital? Simply like basic anatomy of brain that we know, even if we don't know detail, like the middle anterior third has the frontal lobe, middle third has the temporal lobe, and the posterior third has the occipital lobe. Even with that guesswork, can I tell that this is a temporal lobe abscess? Correct. Cerebellar abscess would be in the posterior cranial fossa here, not in the middle cranial fossa. Where we are seeing the abscess, it is in the middle cranial fossa. So don't get perplexed in the examination when you do not know a certain image or do not know a diagnosis. Even with basic information, we can get to the diagnosis. Okay, so a patient present with epistaxis which did not get controlled with conservative methods. The next step of management in this patient will be internal maxillary artery ligation, external carotid artery ligation, internal carotid artery ligation, endoscopic sphenopalatine artery ligation. Now I told you epistaxis, foreign body, stridor, cutthroat injuries, these are common emergencies and you can expect to have questions coming in from here. In fact, every examination from ENT emergencies, one question is definitely asked for. So you will have to know definitely these chapters. So when we are talking about epistaxis or bleeding from the nose and it is not getting controlled with conservative methods, meaning what is conservative methods? By packing, anterior nasal packing, by posterior nasal packing. Then the next step will be ligation of artery. The first artery that we are going to ligate is called as sphenopalatine artery, because sphenopalatine artery is the artery of epistaxis. So this is your artery of epistaxis. Okay, so they have also asked you a question, what is TESPAL in one of the previous years. So TESPAL stands for transnasal endoscopic sphenopalatine artery ligation. So TESPAL stands for transnasal endoscopic sphenopalatine artery ligation. So first and foremost, you're going to do your conservative management. If it fails, then you go to ligation of artery. The first artery that we ligate is a sphenopalatine artery, followed by internal maxillary artery, followed by external carotid artery or the ethmoidal arteries from case to case situation. So this is the order of ligation of artery. Okay, so post-thyroidectomy, the anesthetist observed recurrent cyanotic spells while extubation. The cause of this could be bilateral RL injury, bilateral SLN injury, edema or hemorrhage. Yes, Ayak, you're right. ICA should never be ligated because the main supply to the brain is via middle cerebral artery, which is a part of the internal carotid artery. So we never ligate the ICA. Yes, so post-thyroidectomy, if a patient is having cyanotic spells, it means that the patient's vocal cord are not abducting, meaning the abductors are not functioning, so the patient cannot breathe by himself. Which is the only abductor of the vocal cord? The only abductor of the vocal cord is posterior cricoarytenoid. Now this is again a very favorite question of the examiner. 100 times, 1000 times they ask you abductor tensor. So abductor of the vocal cord is posterior cricoarytenoid. This is supplied by recurrent laryngeal nerve. So if the recurrent laryngeal nerve is paralyzed, the abductor cannot function and the patient will have respiratory distress and stridor. So if there is a bilateral RLN injury, the vocal cords come to lie in midline or paramedian position and they cannot abduct, and when they cannot abduct, they do not allow air to enter, and when they do not allow the air to enter, the patient will have recurrent cyanotic spells while extubation. Okay. See, again the same question, mitomycin C, but you see they have asked you a little bit of different options. So please do make a note of this mitomycin C drug also. So it is used in post-adenoidectomy bleeding, myringoplasty, subglottic stenosis or rhinocerebral mucormycosis. Very good, all of you. We've already learned that it is used for subglottic stenosis, so we will not go into the depth of it. Let's go back to the next question. Post adenoidectomy in ward, the child started to bleed. The next step in the management is take the patient back to the OR and pack the fossa with a hemostatic agent. Take the patient to the OR, remove the clot and ligate the bleeding vessel, cautery or conservative management. Again, these practical questions are definitely asked in the examination. Now they are telling to you that in the ward the child started to bleed, meaning it is a reactionary hemorrhage. And what did I say you for reactionary hemorrhage? Commonly it will be because of slippage of the ligature, or there could be a bleeding blood vessel. So you will have to take the patient to OR immediately and ligate the bleeding vessel, because can the patient aspirate from the nasopharynx? It can go to the oropharynx and larynx. So it's an emergency that first and foremost you please take the child to the OR, intubate, secure the airway, look into the fossa where you have operated. If there are clots, remove the clots, and once you see the bleeder, you coagulate the bleeder or ligate the bleeding vessel. Now a mother got her child with the symptoms of dysphagia. X-ray is given below. The probable foreign body is in the trachea, in the larynx, in the esophagus or in the bronchus. Again, this is a question which is often repeat in the examination. You should be able to answer this very easily with ease. So whenever there is a foreign body on an antero-posterior view, we cannot tell is it in the trachea or is it in the in the esophagus or airway or the digestive tract. We can only say there is a foreign body. But if you see the X-ray lateral view, so if you take a lateral view, you will be able to visualize clearly the column of air shadow in the front. This is your airway, and just in front of the vertebra you will see a soft tissue shadow which will be in grey. This is your soft tissue shadow which is in grey. So you see that the foreign body is impacted not in the respiratory tract, but it is impacted in the digestive tract. So when it is impacted in the digestive tract, typically the location that you see here, this is your cricopharyngeal sphincter. So whenever there is a foreign body in the cricopharyngeal sphincter, you will take the patient in the OR, do a esophagoscopy and remove it. So here the position of the foreign body is in the esophagus. Yes, Mayank, trachea foreign body will present to you with stridor more than dysphagia. Okay. So which of the following are objective test for hearing? BERA, otoacoustic emission, pure tone audiometry, tympanometry. Yes, Priya, you're correct. In this examination they have given the same X-ray and they have asked you the treatment. That is right. So I'm telling you that foreign body in the airway or digestive system is a very important topic and you must keep a note of it. So whenever we talk of objective test for hearing, what do we mean by objective test? That the patient is not giving the response. Who is giving the response? Is the patient giving response, or some sort of a machine or a computer is giving response? So there is an objective assessment where there is little bias for any examiner variation. So BERA is again a machine generated test, otoacoustic emission is a machine generated test, tympanometry is a machine generated test. But in an audiometry, when we give sound stimulus, patient has to raise his hand for those stimulus. So here in audiometry, the patient is giving response. So audiometry is a subjective test. It is not an objective test. So objective tests are number 1, number 2 and number 4, which is in your option B. Now identify the view. Is this your Waters view? Is this your Caldwell's view? Is this your Schuller's view? Or is this your Townes view? So I'll give you a clue because the X-ray is not very clear. The head is forward and not backward. So if the head is forward, what view is it? And you can see the best thing here is the frontal sinus. What is this view? See, in occipitomental view, the mentum will be high, projecting the maxillary sinus. But here the forehead is forward, prominent. So what is this view? Very good. This is your Caldwell's view. So I have told you that X-rays are very important. Please try to go through the X-rays once before your exam. Arrange the components of auditory pathway in their correct sequence. So this is a basic question. I think everybody can answer this. So cochlear nucleus, inferior colliculus, lateral lemniscus, medial geniculate body, superior olivary complex. So we remember the mnemonic it as E. coli ma, right? So 8th nerve, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body and auditory cortex. So the order is first and foremost the 8th nerve, after that your cochlear nucleus, after that your superior olivary complex, after that you have the lateral lemniscus, inferior colliculus and medial geniculate body, which is given in your option B. Endoscopic view of right nasal cavity is given below. What is the structure that has been marked? Is this your inferior turbinate? Is this your middle turbinate? Is this your superior turbinate? Or is this your uncinate process? So what is this image showing you? This is again a very easy question. So typically when you see the nose, you see on the midline there is a straight structure or it can be bent structure, which is your septum. In the lateral wall we have projections. The inferior turbinate inferiorly, middle turbinate in the middle and superior turbinate superiorly. When we do an endoscopic examination, the immediately visible structure will be inferior turbinate laterally and septum medially. Middle turbinate we can see as we go further inside, and superior turbinate is rarely visible. It is visible only after thorough decongestion. So inferior turbinate is the structure that you can see here in a patient with the endoscopic view. All the following are seen in otitis media except Bezold's abscess, Griesinger sign, Battle sign, Delta sign, meaning all the following can be seen in complications associated with otitis media. So which of them is not associated with complication of otitis media? Absolutely right, all of you got it right. It is Battle sign. Battle sign is seen whenever there is a trauma, where you get a discoloration, a bluish discoloration of the mastoid. There you get this Battle sign. Typically it indicates a middle cranial fossa fracture. So this indicates usually a middle cranial fossa fracture. Okay, a 15-year-old boy came with complaints of fever and dysphagia. Tonsil was found to be swollen in the patient. A surgery was performed on the patient. What is the source of post-tonsillectomy bleeding? Peritonsillar vein, external palatine vein, ascending pharyngeal artery, facial artery. So most common source of bleeding is, very good, it is from the peritonsillar vein followed by tonsillar artery, which is a branch of facial artery. That tonsillar artery is not even given in your option. So peritonsillar vein will be your answer. Which of them is not a major criteria for diagnosing allergic fungal rhinosinusitis? Nasal polyposis, positive fungal culture, characteristic CT findings without invasion, allergic mucin discharge showing fungal hyphae. So which is not a major criteria? So there is a criteria for AFRS which is called as Bent and Kuhn criteria for allergic fungal sinusitis. Very good, most of you have been able to answer this right. So typically wherever we talk about allergic fungal rhinosinusitis, when we say allergy, should there be elevation of serum IgE levels? Yes, so serum IgE level should be elevated. When I say fungal, should the KOH mount or fungal stain be positive? Yes. So KOH mount or fungal stain is positive. Rhinosinusitis, meaning should I have allergic mucin? Yes, you should have allergic mucin in the nose. You should have nasal polyps also. So allergic mucin, nasal polyps, and the last thing is characteristic radiological sign. What radiological sign do you see? The radiological sign that we see in AFRS is double densities. So this characteristic radiological sign is a feature that you see in allergic fungal rhinosinusitis. So fungal culture positivity we are not including. Why are they not including? Because fungal culture takes a long period of time, but if I want to establish my diagnosis, I want a test that will tell me immediately whether this is fungus or not, which is done by fungal stain or KOH stain. Fungal culture takes about 1 month. So to label a patient AFRS, I am not going to use fungal culture, I am going to use fungal stain. Okay. A 10-year-old boy came to your OPD with the following facial features. What is true about the diagnosis? So you can see open mouth, you can see that the dentition is improper. What do you think is the diagnosis? Frog face, adenoid facies, horse-like face, golden hair syndrome. Yes, absolutely right. I don't need to explain it as adenoid facies. Frog face deformity is seen in juvenile nasopharyngeal angiofibroma, where you see widening of the nasal bridge, bulging of the cheek, proptosis of the eyes. That is seen in JNA. Horse face is nothing to do with ENT. Golden hair syndrome, again we are not going to have features like this. So adenoid facies is something that is going to tell you mouth open, improper dentition, high arched palate, hitched lips, pinched nose, elongated face, all that is suggestive of adenoid facies. Identify the marked structure in the given CT scan. So I think they have marked the structure here. Let me mark it with another color so that it becomes easy for all of you. What is this structure? Again, if you see CT of the paranasal sinuses, the questions are coming quite often. So a quick understanding of CT of the paranasal sinuses is very essential. Yes, so this is your pneumatized superior turbinate. So this is your inferior turbinate, this is your middle turbinate, and this here that you see is your superior turbinate. Now here in the image that you see, which is marked with a star, it is air filled. So whenever there is an air filled middle turbinate, superior turbinate, we call it as pneumatized superior turbinate. Agar nasi will be seen here near the orbit, between the middle turbinate and the orbit, because it's an ethmoidal air cell. Concha bullosa is pneumatized middle turbinate. So what is concha bullosa? If the middle turbinate is pneumatized, then we call it as concha bullosa. And what is Onodi cell? I have already explained to you. It's a posterior ethmoidal cell extending into sphenoid sinus. So Priya, supreme turbinate is rarely seen. We do not have in all patients. At the moment in the scan I cannot see it, so I cannot show you. Okay. Okay, a patient was operated for safe CSOM in the right ear, following which he complains of vertigo, tinnitus and fullness of the ear. The symptoms improve on keeping the right ear up. What is the most likely diagnosis? Labyrinthitis, perilimb fistula, vestibular schwannoma, Paget's disease. So after surgery, meaning it was a safe CSOM only, tubotympanic type of CSOM, patient is now having vertigo, tinnitus and fullness of the ear. And when the patient puts his head up, he is having better improvement. What does it indicate? Yes, typically when we do a surgery in the middle ear, there is always a possibility that you can cause trauma to the oval window or to the round window. So when you cause trauma to the oval window or to the round window, the perilymph can leak from the scala vestibuli or the scala tympani into the middle ear, and when that happens the patient can have imbalance, can have tinnitus, can have fullness in the ear. So for this condition you must think the probability of a perilymph fistula, and this typically with positional variation, when the head is up the patient feels better, is again an important finding that will tell you. Now in labyrinthitis the patient will not tell you episodic, in terms of position it will not be there. Second thing, in labyrinthitis the patient patient will have fever and it is a continuous vertigo, tinnitus and fullness of ear. Unlikely that when the patient puts his ear up it will decrease. It doesn't happen that way. Vestibular schwannoma is a tumor, and Paget's disease is a type of a disease where you see excessive bony deposition rather than a fistula or a communication. Yes, Priya, if there was no history of surgery, you would think of mean ears. That's right. So management of perilimb fistula, you have to go and close the fistula because there is a communication, Mayank, between the middle ear and inner ear. You have to go and seal that fistula and close that fistula. You'll have to redo a surgery. Okay. So a 70-year-old male presented to you with nasal obstruction, blood-tinged nasal discharge. His endoscopy and CT scan are shown. The most probable diagnosis is, typically you can see finger-like projections with blood-stained discharge, and you can see the disease has eroded the bone and going into the nasal cavity, into the maxillary sinus. What is it? Very good. This is called as inverted papilloma, also called as Ringer's tumor, also called as Schneiderian papilloma. This is a condition which is a benign condition, but it has a potential to transform into malignancy. So this is benign, but it is pre-malignant. It is known to arise from the lateral wall of the nose, but it can go and spread into the maxillary sinus as well. So it can arise from the lateral wall of the nose, can go into the maxillary sinus, can go to the rest of the nasal cavity as well. So even though it is benign, it is locally spreading, it is locally invasive. And this tumor basically goes, the projections or the finger-like papilla go not towards the surface but inside or towards the stroma. That is why it is called as inverted papilloma. Which of the following does not constitute post-laryngectomy rehabilitation? Polite yawning, supraglottic swallowing, esophageal speech, tracheoesophageal prosthesis. Okay, so yes, Vipul, HPV is a risk factor for inverted papilloma. Correct. So which of the following does not constitute post-laryngectomy rehabilitation? So when we're talking about laryngectomy rehabilitation, we know speech is a very, very important component for rehabilitation, and for that we give esophageal speech and tracheoesophageal speech. So they do constitute. So these two are out of our options because they do constitute the part of management. Now when we do laryngectomy, do you think swallow will be the same, the process of swallowing? Because there is no larynx. So whenever we have a normal swallow, there is an effective coordination between our oral cavity, oropharynx, larynx, hypopharynx, and then the food goes to the esophagus. So once there is no larynx, do you think the reflex mechanism is the same as before? It is not. So the patient has to be taught swallowing and he has to be rehabilitated for swallowing, for which we do a maneuver called as the supraglottic swallowing. Now you don't need to learn that maneuver, but just remember swallowing rehabilitation also has to be done. But why do we want to ask for yawning? Like even if you don't know this question, in the worst case scenario also, why will we rehabilitate anybody for yawning, right? Obviously we won't. We will rehabilitate for swallowing and speech because they're essential thing. Like for peeing, for swallowing, for breathing, you don't have to struggle. They are something that should come naturally and spontaneously to everyone, even if you have undergone a surgery. So essential things you rehabilitate. Yawning is not essential. Even without yawning, like whatever kind of yawn, it's okay. So yawning is nothing to do with rehabilitation. Yes, of course, dreamer olfaction will be impaired because air currents are going through the tracheostomy and they're not going through the nose. So again, they will have anosmia and hyposmia. So again, smell rehabilitation can be done in patients with post-laryngectomy. Which of the following method of rehabilitation should be done in a child with atresia of the external auditory canal? So they are giving you a question where a child is having atresia of external auditory canal. Yeah, so what should be used? Yes, Anurup Rathod, not constitute is yawning. The rest of the three form a part of management post-laryngectomy. So the first one that you see here, this is called as a total ossicular replacement prosthesis. The second one that you see here is a BAHA. The third one that you see here is a hearing aid. And the fourth one is basically a tuning fork. So here when we talk about atresia of the external auditory canal, what we are going to do is we are going to give a bone anchored hearing aid, because the sound impulses bypass the external ear and middle ear and they go towards the inner ear. Okay, so this completes your 22 and 21 questions. I'll come back again with more questions. Actually, there have been more questions that I had thought I'll do with all of you, INI-CT questions. But having said that, right now I will be ending the session, but I'll come up with more more MCQs of the rest questions that we are left with very soon, so that we can cover the rest of the questions as well. Okay. Yes, so with this I'll take your leave. I hope you guys enjoyed the session. I do want to continue the session, but there are many more questions. I'll require another hour to do so, and right now I have a little bit of commitment as well, which is why I cannot continue even though I really wish to. But I'll come back surely. I give you a promise that I will come back and continue the rest of the class. Okay. Vipul, I didn't get your question about speech. I didn't understand. I don't know if I've missed some of the questions during the live chat, because I'll be explaining intermittently. I'll see the phone, so I don't know. No, Vipul Joshi, esophageal speech is a very important part of rehabilitation. Those who are not fit for tracheoesophageal prosthesis after laryngectomy, we train them with esophageal speech only. Okay, so esophageal speech, tracheoesophageal speech, electrolarynx, swallowing, smell, all of these are part of rehabilitation. But yawning is not a part of rehabilitation. Yes, I will do the rest of the questions very soon, Mayank. And Anurup, yes, next 2023 is most likely to happen with so many notifications coming off late. December 2023 could be the time when next examination can start. But don't panic. It's not going to be something out of the blue. It's just going to be that a little bit of change in pattern, a little bit of assessment of your knowledge will be done. So you will get used to it. It's going to be new for everyone, not just one of us. So let's just take it when it comes. Let us not think too much about what's ahead in the future, and let's just do what we are supposed to do right now, which is studies. So let's prepare, keep ourselves on the track, and let's forget about what's going to happen in the future or what's going to happen later, and right now let's just focus on our studies. Yes, Hashirama, tomorrow morning 7:30 a.m. I have a plus class where I'm going to do image based questions on rhinology, so you can attend the plus class tomorrow. Okay, so take care guys. It was lovely interacting with all of you. I will see you again very soon. Until then, bye bye.